Maternal collapse demands instant recognition, rapid coordination, and decisive action. I invite Dr. Anil Satyadas, Government Medical College, Thiruvananthapuram, one of the pioneers in this field with many years of experience, to the stage.
Respected chairs, good morning delegates. So after someone has made a painless delivery, suppose, or even before, we have a 32-year-old lady, 39 weeks cephalic presentation. She was taken for LSCS, the baby was extracted. Placenta have been removed and uterus feels flabby. There is no evidence of BPH at present or tear. On examination, the patient's BPH drops to 70/30. Pulse rate, bradycardia, saturation falls. So when you have such a situation, what we should be doing is think out of the box also. Look back at your machine. And of course, you have to keep in mind the timeline, whether it is peripartum, where you can attribute the problem to either obstetric causes or anesthetic causes. Look around, see the responsiveness of the patient. That might not be possible when the patient is in GA. That also decides whether you would go for compressions first or you maintain the airway. Specifically important, look for drugs that were given immediately before. Maybe antibiotic was given, look for anaphylaxis. Two important things to look on your Ball's machine is your end-tidal convex and FiO2. Look at the level of spinal anesthesia and of course the epidural. Have the background in your mind. Keep the differentials like amniotic fluid embolism, high spinal, toxicity of local anesthetics, and others. So we'll discuss few of them. This is my topic, and in 15 minutes, I'll try to finish off. So next question that would come to our mind is whether can we detect them early? Yes, we have a lot of early warning scores, like modified, specifically modified for obstetrics. We have one for sepsis also, that is obstetric modified QSOFA. You have mini Prius for your PIH, and then this is the QSOFA that has been modified for pregnancy where the systolic BP is less than 90 and the heart rate is more than 25. Instead of the 122, we have for non-pregnant patients. And these mini PS also can be applied to healthcare workers where they can detect complications of PIH early. So what is maternal collapse? Of course, it's an acute event. We would not have time. It's basically affecting the cardiorespiratory as well as the CNS at any stage in pregnancy up to 6 weeks after birth. And what is important is that it can progress to cardiac arrest, maternal cardiac arrest. And most of the time, we would be on fire. Others would be on the opposite side saying, okay, you can manage, you go ahead. That's a difficult scenario. We would have little help. So always keep in mind the causes, the standard BU chops. We'll not go into the details there. We'll come to discuss many of these. One of the main things that affect the outcome or difficulty in restarting pregnant patients are the changes that occur, where the mother would have a poor cardiorespiratory reserve. So you have altered gas targets. The PO2 should be maintained around more than 70 millimeters of mercury. Also, carbon dioxide should be maintained normal because if the carbon dioxide goes high in the maternal blood, your carbon dioxide from the fetus will not come into the mother, and you'd go have an acidotic fetus. You have the compressions decreasing the preload as well as the afterload. Early desaturation because of decreased FRC as well as increased demand. Low colloid oncotic pressure predisposing the patient to pulmonary edema. There would be risk of aspiration because of regurgitation. There will be ongoing drugs that would potentially cause hypotension like uterotonics and magnesium. Of course, your anesthetics are always there. And we are dealing with not just one life, 2 or more lives. So we have a scenario where the disease process where the mortality is more than 50%. Its incidence is a bit less. Diagnosis rule out other causes. Does not have a correct diagnostic criteria. It's called as anaphylactic syndrome of pregnancy, and we are going to talk about amniotic fluid embolism. Previously, we had the obstruction of the pulmonary vasculature causing problems, but the evidence has changed to immune activation of inflammatory mediators producing something called cytokine storm. And because of severe vasoconstriction in the pulmonary vessels, we have RV failure initially, which might be transient, leading on to progressing to LV failure, pulmonary edema, pulsus activity, and cardiac arrest. There would be severe hypoxemia, hypotension, and coagulopathy. It can lead to ARDS, altered mental status, seizures, cerebral ischemia or bleed, and even fetal bradycardia and death. So, two phases have been described where there's entry of amniotic fluid producing immune activation of vasospasm, producing RV failure, and then the phase 2, the inflammatory storm producing cytokines, leukotrienes, and thromboxane producing DIC. All things occur very fast, and in 15 to 20 minutes time, you might have a patient in cardiac arrest. There is one diagnostic criteria for you to diagnose AFE. So you have a cardiorespiratory arrest or hypotension with respiratory compromise, DIC score more than 3, and clinical onset during labor or within 30 minutes of placental delivery, and there should not be fever during labor. Coming to the RV failure that occurs in the initial part, that is usually transient. It increases pulmonary pressure. Echocardiography would be able to diagnose, but that should be done in the time period. So RV failure might tolerate a bit of fluids, but don't give too much. 250 to 500 ml boluses can be tried. And the choices of your vasopressors or inotropes would be noradrenaline, dobutamine, and milnacipran. Other options for pulmonary vasodilatation include nitric oxide. ECMO is one option you should keep in mind because it's a reversible cause. Always monitor the fetal heart also. So when you come to the RV failure, a simple echo, a 4-chamber view with TAPSE would help us diagnose RV dysfunction. So this the second picture shows a severely dysfunctioning RV. You have normal TAPSE of, that's how high the tricuspid annulus moves with systole. And coming to the management, unfortunate to have, there's no definite management, it's always supportive. The typical emergency care, ABC, IV access, above diaphragm, 100% oxygen. CPCR, when you start, always think of manual uterine displacement. Delivery is a priority, but timing should be optimized. Restate a hysterotomy at the place of collapse. Hemodynamic monitoring, advanced even arterial line would be helpful. And monitoring the DIC part would be with the help of point of care tech. Once you have intubated, you go for lung protective ventilation, the pressures would be high. Uterotonics for atony, and then something called as a AOK regime, that's atropine, ondansetron, and ketorolac, not with good evidence, and also the 50-50-100, use the diphenhydramine, famotidine, and hydrocortisone, again, not with good evidence. When you come to DIC for amniotic fluid embolism, your options include your massive blood transfusion, tranexamic acid, FFA cryoprecipitate, but factor 7A have shown to have poorer outcome in patients who have DIC in amniotic fluid embolism. Your coagulation targets would be around hemoglobin of 7, platelet of 50 to 75,000, fibrinogen of around 1.5 to 2, and APTT of less than 1 times the normal. Other management would include your vasopressors and inotropes, NORAD being the first. Vasopressin has, it increases the uterine contraction, so it's less preferred. ECMO being reversible, you can consider ECMO early. Coming to the most important part, the delivery of the fetus. Restate a hysterotomy, especially if the baby is more than 20 weeks of age. You should be done within 4 minutes and fetus should be out by 5 minutes. Perimortem operative vaginal delivery can also be tried, provided it is done within the timeline. It is done at the site of arrest. Don't shift to OT. Manage post-delivery uterine bleeding according to standard methods. So the question that would come is when to activate the restated hysterotomy. So when you want the procedure to be started at 4 minutes if there is no ROSC and complete by 5 minutes. So the answer would be as soon as the cardiac arrest is identified in pregnant patients, don't forget to activate the hysterotomy team also. Suppose our patient worsens, the hypotension worsens, and patient starts to bleed. So think of PPH, the 5 T's of PPH. The management of PPH would include, of course, massive blood transfusion or massive hemorrhage protocol, as it's now called nowadays. You have your institutional protocol. Here we can give factor 7A, and that also another option is your prothrombin complex concentrates, where It might not have much role in atonic PPH, whereas it can be considered in patients who have DIC and bleed. Fibrinogen concentration is also another option. In critically low levels, when it's especially less than 100, and there is no availability of FFP and cryo, you can use that. 50 ml vial contains approximately 1 gram of fibrinogen, and dose is weight in kg into desired increase in milligram per deciliter divided by 1.7. So when to activate the massive hemorrhage protocol, we have different things, especially with related to trauma. We have discussed that earlier. So I think the first one would be better for pregnant patients. That is more than 3 RBCs within 1 hour. That is the moment you think of activating the massive blood transfusion protocol. Then we come to the next scenario, which is pulmonary embolism, because our patients are prothrombotic. And when you suspect pulmonary embolism in a pregnant patient, you have something called the Years criteria. Basically, it's look for clinical evidence of DVT, whether there is hemoptysis, and see if pulmonary embolism is the most likely diagnosis. We have excluded other causes. That's called as the Years criteria. So if there are signs of DVT, what the advice is to go for an ultrasound of the leg and see if DVT is there. If there is there, treat. And there is no DVT, order D-dimer, because D-dimer would be elevated in pregnancy. The cutoffs are a bit different. And what is the importance of years is that depending upon the scoring of the years, you can divide patients into two. One group would have 0 years criteria, where the D-dimer cutoff is more. Usually it's 0.5, now it has come to like 1 or 1000. And the other one is more than 5, where you have the cutoff as 500. The CTP is a gold standard, and echocardiography would see patients having RV strain pattern with IVC being dilated and loss of variation, respiratory variation. Paradoxal septal movement can also be done. Management of PE, the controversy here is that whether patient would be able to shift it to the angiosuite to do the CTPA. And the options would be unfractionated heparin and thrombolysis. So studies have found that thrombolysis in passive pulmonary embolism in pregnant patients is associated with higher maternal and fetal survival. Okay, that's quite good. And risk of bleeding was 17.5% if it's done before delivery. Whereas if the patient is to be lysed after delivery or postpartum, the mortality or bleeding tendency would increase to around 60%. So pre-delivery, you think of lysis, but post-delivery, go for surgical thrombectomy or catheter thrombectomy or ECMO. There have been also guidelines to say if you don't have the confirmation, you do not shift the patient for CTPA, but then you really suspect PE, you can still go for thrombolysis, but then it comes at a cost. Coming to the next scenario, PPCM. Every student should be able to identify such a poor heart. Definition-wise, it is less than 45 ejection fraction and end diastolic dimension more than 2.7 centimeter per meter square body surface area. We have a high pro-NT-BNP. Treatments include nitrates, hydrolyzine, very difficult to manage such patients. And cardiac MRI with gadolinium is contraindicated, should be avoided as it crosses the placenta. ACs inhibitors also contraindicated. Anaphylaxis, the standard regime would apply. So 0.5 ml, 1 in 1000 IM is what we have to give. We have to look for the diagnostic criteria also, and they advise to do mast cell tryptase level as evidence for anaphylaxis. Coming to the lipid overdose, intralipid is, local anesthesia systemic toxicity. Intralipid is a drug of choice. You have to give 1.5 ml per kg. Over 1 minute. That is usually 100 ml for a 70 kg patient. You can repeat that twice. So the dosage would be 100 ml, 100 ml, 100 ml every 5 minutes if your hemodynamics are not maintained, followed by an infusion of 15 ml per kg per hour. So that's around 1000 ml per hour, and which can be increased to 30, that is 2000 ml per hour after 5 minutes if circulation is not restored. And the CPCR, here is the moment you think of continuing a CPCR as long as an hour, because it can come back. So continue your intralipid and continue your CPCR. And if unfortunately our patient goes into cardiac arrest with all what we can do have been done, you think of the etiologist. It's like BUCHOPS itself, it's been put as A, B, C, D, E, F, G, H. And this is the newer chain of survival we have incorporated in hospital and out of hospital into one chain of survival. The standard regimes apply, but the major important things you should always keep in mind that you should not stop your compressions for an airway, though early intubation has been advocated. So left uterine displacement, don't forget, IV above diaphragm, stop magnesium if it's ongoing. Early airway, restorative hysterectomy, massive blood transfusion protocols and teamwork always works. Coming to another problem, it's a sepsis. Yes, guidelines are very similar to non-pregnant patients. So you give fluid resuscitation, antibiotics, and NORAD and vasopressin. Then coming to eclampsia or seizures in pregnant patients, these are our differentials, and eclampsia is defined as a new onset of tonic-clonic. It could be focal and multifocal also, but the general description is tonic-clonic conversions, where other causes are ruled out. And if the patient does not have a background hypertension, you still have a seizure. You can diagnose eclampsia by having the typical clinical and neuroimaging findings of PRES. PRES can occur without eclampsia or PAH, but then it's usually associated with eclampsia or PAH. So what are the other associations? Hypertension, headache, visual disturbances, and right upper quadrant pain or epigastric pain. Coming to the management of eclampsia, you have the airway, breathing, circulation. Place the patient lateral decrepitous position. Magnesium is 4 grams, usually 4 to 6 is what is being said over IV over 20 minutes, followed by 1 to 2 gram per hour. So if the seizures recur, you can add a bolus of 2.2 to 4 over another IV over 5 minutes. Also have other pitch charts and suspend regime, like you give 5 gram over the buttocks on each buttocks, 10 gram IM. Seizures are also usually self-limiting. So magnesium does not stop the seizure, it prevents further seizures. So if it's refractory, you can think of Eptoin, lorazepam, and thiopentone. You of course have to take care of the BP with hydralazine, levetolol, nifedipine, and delivery of course at the right time. Coming to magnesium toxicity, last slide. So the normal is 1 to 2. So it's given in milliequivalents per liter. So that is easy to study. So when you asked what is the therapeutic range, it's 2 to 4. When you go to toxicity, it's 5 to 10. You have ECG changes. When it's 10, you have the deep tendon reflexes. So that's a common exam question. How do you clinically monitor and you think of withholding magnesium? It's the value of 10 milliequivalents per liter. You have muscle weakness. So ECG, then muscle weakness, then again ECG problems with muscle weakness. There is a respiratory paralysis also do set in. And cardiac arrest usually sends in 20, or in some books say it's 30 milliequivalents per liter. So if you look at what we get in the labs is usually milligram per deciliter. So if you want to convert that, 1 milligram is equal to 0.833 milliequivalents. So what you do is stop magnesium, and the antidote is calcium, which is a physiological antagonist. You have to give 10 ml 10% over 3 to 5 minutes, and further doses are again advised. Of course, diuretics and dialysis do help. Documentation is very important. You have to because it usually will become an MLC, and it should be reported, incident reporting, and also should be reported to other higher authorities. We should have that audit being conducted also. So I hope most of my topic guideline, reference was from the Green Top Guidelines number 56, and others have been added as per the updates, and hope you have a very clean patient, which is a rare possibility at the end of your research. You have a very dirty looking OT or labor room. Thank you so much.
Thank you, sir. You have reminded us that preparedness saves 2 lives at once.